Hi, everybody, and welcome. It's my pleasure to open this webinar with the main focus of Li-Fraumeni mutations. This is a mutation in the TP53 protein. I'm joined here with Lynn, our nurse practitioner, who is really running the adult hereditary cancer clinic, and Dr. Jennifer Michlitsch and Dr. Arun Rangaswami, who both are focused on more children and young adults. And if I may, Beth, would you quickly introduce yourself?
Sure.
What
Hi.
you see and what you do?
Sure, I will. My name's Lynn. I know a lot of the adult patients that are seen in our clinic, and what I do is when new adults join our clinic, we look at family cancer history and talk about appropriate screening. There's a couple of sets of guidelines. There's a older set of guidelines that was based on childhood Li-Fraumeni screening that at least we initially used. More recently. There's a national set of guidelines, and we've tried as much as possible to harmonize the two. And basically, I work with people to make sure that we keep their exams up to date, all their screening. If they have any new symptoms, we work them up.
And before we go into more details, what this syndrome really is and how many cancers and what type of cancers is had, I'd like to ask Dr. Michlitsch to introduce herself.
Hi, everyone. I'm Jen Michlitsch. I'm a pediatric oncologist. Thank you so much for having me today. I treat children and young adults with cancers, and I'm also part of the Pediatric Hereditary Cancer Clinic. I'm mostly based in the East Bay, in Oakland, and I see patients along with one of our geneticists and one of our genetic counselors. And we offer in-person visits as well as Zoom visits. And we see children. These children are patients of ours who have a cancer, and we discover the underlying germline genetic alteration that the family had previously been unaware of. And other times we have patients referred to us due to the presence of a genetic mutation in a family member, and then the child is tested. So we meet with families, go over the diagnosis, go over the surveillance protocols, and then really help to coordinate all the necessary visits and labs and scans, et cetera. So really happy to be here.
Thank you for joining us. Dr. Rangaswami.
Yeah, I also would like to express my gratitude for being invited to participate in this panel. My name is Arun Rangaswami. I'm also a pediatric oncologist. I focus principally from an oncology perspective in solid tumors. And like Jen, I'm part of the hereditary cancer clinic in pediatrics, principally based in the West Bay. And I think Jen gave a beautiful summary of our multidisciplinary approach to caring for children and adolescents and young adults who have a variety of cancer predisposition syndromes, including Li-Fraumeni. We also have forged a close institutional relationship with Dr. David Malkin at Sick Kids, and in fact, he was recently down last week to give a talk to our group and share some of his data. So it's a really great privilege to be here.
Thank you all. And so before we go into details of Li-Fraumeni and what it is, it's like a little bit of like, why do we need a specialized clinic for this, Beth? Why can't people just go to the primary care doctor and get all this done? Or like, why can a general pediatrician not see these patients? Beth, you want to start?
Certainly.
What is it you're doing differently than a primary care physician could do?
Well, the first thing is hereditary cancer syndromes. The important word in there is cancer. In primary care or any kind of general care, the focus is on wellness and not in oncology. And so For example, a primary care provider would not necessarily know what symptoms to be looking for sarcomas, or what type of physical exams to be doing when your big concern is a brain tumor. And so certainly any healthcare provider can learn to do all these exams, but in primary care, their focus is on health wellness, vaccines, and general exams, and keeping people up to date on their regular screening. And in these hereditary cancer clinics, we really focus on very specific sets of diseases that are associated with individual mutations. And so it's focused on cancer, and it's focused on detection and, where we can, prevention.
So, Dr. Rangaswami, how does someone end up in your clinics? Like, how do they find you? Who refers you to a clinic?
Yeah, so we have a couple of different ways that patients enter our clinic. One is, of course, a family or a patient who has a known diagnosis of cancer, for whom we do germline testing and then identify, a Li-Fraumeni associated mutation. And there, of course, while the primary focus is on treating the cancer diagnosed presently, we also do, start to discuss screening and transition patients from active surveillance of cancer to the cancer screening guidelines that have been set out, in the Toronto Protocol. Then there are the children of, parents who've been diagnosed with Li-Fraumeni syndrome who themselves have not yet developed a cancer, and they are tested after meeting with one of our genetic counselors if they choose to pursue testing. And then when a mutation is identified, they come to our clinic, and we do a lot of education, and we also initiate the screening guidelines in that situation. And then there are patients who are identified through germline testing, that's done for a variety of reasons, where the primary intent was not to uncover a pathogenic mutation, and yet one is identified. And then they are, of course, referred to our clinic as well. So it can be, through different routes that we end up in seeing our patients.
Again, I assume, Jennifer, the same is true for you, the similar referral base.
Exactly, yes. We're actually, we have a joint PHCC across the Bay, which is really nice because we have a lot of minds thinking about every patient and every case, and we have a meeting monthly, at least monthly, with all of our providers. And so we sort of keep up to date on not only new referrals, but existing patients. So it's really sort of a single referral process, and then we're able to triage patients to either in-person visit in one campus or the other, or a video visit, or we really try to work with families to accommodate what works best for them.
Great. So what is Li-Fraumeni syndrome? Like, what is the mutation? Who gets it? Are you always getting it from a parent? Can you get this from someone spontaneously? Can someone get it spontaneously?
Do you want me to take that one, Jen, or do you want? I'm happy to take it. Yeah,
Sure.
so
Yeah.
Li-Fraumeni syndrome is characterized by a mutation in a gene called TP53. And it's a tumor suppressor gene. So it's a gene that in its wild type, or in its natural state, prevents the development of cancers through a variety of different biological pathways that involve the tissue microenvironment. Mutations in this gene can result in an increased risk of developing childhood and adult cancers. These mutations are what we call pathogenic mutations, or likely pathogenic mutations. And it is an autosomal dominant condition, so that the risk of transmission is relatively high. The challenge with Li-Fraumeni syndrome, as I'm sure all of these panelists are aware, is that there is actually a spectrum of mutations. There is what we call classic Li-Fraumeni syndrome, which is a set of criteria, the Chompret criteria, which take into account family history as well as the presence of a genetic abnormality to outline what meets the threshold of classic Li-Fraumeni syndrome. And then there is attenuated Li-Fraumeni syndrome where patients are outside of the Chompret criteria. So perhaps the frequency at which the cancer occurs within the family is much less than what is required in the Chompret criteria. The overall risk is quite high for developing cancer when you go into adulthood, higher in females than in males, around 90% in females by the time they reach the age of 70, and more like 75% in males. And that probably has to do with the risk of breast cancer in specific, that is, obviously more common in females than in males.
Thank you. So Bess, in your adult clinic, what are the cancers that you see most commonly associated with the Li-Fraumeni?
Sure. For women, it's breast cancer. Far and away, it's the highest risk and the largest number. And many of the female Li-Fraumeni patients make the decision to undergo mastectomies quite early, like in their early 20s, or as soon as they become aware of the mutation, in order to avoid that cancer because the risk is so high. After breast cancer, we have a number of people who have had brain tumors, although a number of those have developed in childhood, but there are a couple that have developed during young adulthood. We have a number of patients who have had sarcomas, both men and women. Interestingly, in our clinic right now, all of the sarcomas were adult onset. And there's more men who've had sarcomas than women. And then we have a large variety of a bunch of other cancers, a lot of skin cancer, a lot of ovarian cancer in a couple of our female patients, and at least one prostate cancer in a male.
I think in the classic and most common cancers, repeating are probably breast, brain sarcomas. And then I think it has to be just very important to know that a mutation in TP53 enables cancer. This is a cancer enabler, and I think so. It's really important for any family member who has a mutation like this to just be aware that other cancers can occur, and that we should pay close attention to this. So thank you for this in the adult clinic, and Arun, you've told me before, like as a pediatric oncologist, you don't see a lot of breast cancer, which is great. But Jennifer, what are the cancers that you see in the pediatric clinic in patients with Li-Fraumeni syndrome?
Yeah, I think to some degree similar to some of the adult without the breast cancer. So as Beth was mentioning, we see a lot of patients with sarcomas. So either what we call soft tissue sarcomas, like rhabdomyosarcoma. We see osteosarcoma, which is a bone cancer. We see many children with brain tumors as well. Some patients with a tumor of the adrenal cortex called adrenocortical carcinoma, which is a pretty classic cancer associated with Li-Fraumeni. And then we see a number of patients with leukemias, actually, who are found to have underlying Li-Fraumeni syndrome. I think those are probably the top four. But as you mentioned, we are screening and looking for all types of cancers because we know that there are other types of cancers associated with Li-Fraumeni, absolutely.
So Um, when do you start screening? Let's say someone knows that they have a, let's say someone in their 30s has a child with and when should they test their child?
Yeah. Do you want me to take that, Arun? Okay. Yeah. So, I think the recommendation is to start screening from birth. We like to meet with families really initially, mostly for an information, gathering and providing standpoint because a lot of these surveillance tests are very different in children as they are in adults. For example, imaging studies. So one of the recommendations is to do a whole body MRI and a brain MRI. And in small children, very often this involves sedation with anesthesia to have scans. And so we really need to talk to families to, review the risk benefit ratio of doing anesthesia. Sometimes we have families that feel more comfortable waiting until the child is slightly older. Other families want to get the imaging surveillance started right away. And I think that's part of the art of the clinic in general is really figuring out where each family's sort of comfort level lies and working with each individual patient and family to figure out the best path forward. But I think the sooner we're able to see families and patients and really start that discussion, the better, so that we can catch the cancers as early as possible.
And Arun, sidetracking here a little bit is like we often get asked, like, why can't we do the whole body MRI and the brain MRI? Why do we need the brain MRI and the whole body MRI? And our radiologists feel very strongly that you should separate them because they're different exams. Can you be a little more specific why people have to do both MRIs?
Yeah, absolutely. So the whole body MRI is a good screening tool, particularly for identifying tumors in the thoracic, in the chest, and in the abdomen and pelvis. However, it is not very good or very sensitive for identifying small tumors in the brain. And so dedicated brain MRI is significantly more sensitive. And so you can miss a smaller brain tumor on a whole body MRI that you will see on a dedicated brain MRI. And so that's principally the reason why we do both.
That's very helpful. And best we do the same for adults, right?
Sorry. Yes, that's correct.
So basically, if we want to have a whole body MRI and we want to have a specific brain MRI because they're different tests, and maybe we can stagger them a little bit so we don't have to have too much contrast and like. So we talked a little bit about getting a Li-Fraumeni from one of the parents, but can these mutations be spontaneous? Jennifer, if you want to answer this.
Yeah, absolutely. We know that they can be spontaneous, in fact, so we call that de novo mutation, and that would be a situation where neither parent has the mutation in the TP53 gene, but one of their children does develop that mutation. And, there's ongoing a lot of research into all of the different types of inheritance and de novo mutations and alterations. But at this point, I think we really don't understand why some children develop this sort of mutation. We know that in families where parents do have an alteration, oftentimes we see a similar pattern of cancers in the children as the older family members, but it's not always the case. And so I think that's really why it's important for us to have a geneticist and a genetic counselor involved in helping talk to families about exactly how this was inherited or whether it was a de novo mutation, and then sort of whether we would tailor our recommendations at all or go with the standard surveillance for each individual case.
Okay, so but then how does someone find a spontaneous mutation? Do you see patients who get tested without having a cancer? Is it predominantly people who have cancer and then find out that they have a mutation?
Yes, great question. That is primarily going to be patients who have a cancer. and then are tested for a germline mutation, and we pick it up that way. So we currently test pretty much all of our patients with cancer, both for somatic or tumor mutations and also for what we call germline mutations, which is the whole body. And we have looked at our test results and found that many patients in some populations, greater than 20% actually, are found to have a germline alteration. And then often there's no history of known alterations. There's no history of cancer in the families. And when we go on and test the parents, sometimes we don't find it. So that's the number one way in which we find patients with de novo mutations. The other possible scenario, which happens less often, as Arun mentioned, would be a child having a workup, a genetic workup for some other reason, who is then found to have a mutation in TP53, for example.
Yeah, and interestingly, as you know, like almost all ovarian cancer have TP53 mutation in the ovarian cancer. Very few patients have a germline mutation. So I think it's still like if a tumor has a BRCA mutation, that always prompts BRCA testing. That's not true for TP53 because it's so common, and so we see so many TP53 mutations on tumors that are not germline mutations. So when would you guys recommend to do germline testing? Now, my opinion has always been everyone should get germline testing. So, but asking more the experts who see children, who
Yeah.
should get germline tested for TP53?
Do you want me to take this one, Jen?
Yeah.
Okay. So we share that opinion. So we actually have an SOP currently where all pediatric patients they receive both germline and somatic testing. Part of the reason for that is because cancers in young children or in younger adults and adolescents is a feature of most cancer predisposition syndromes. So the rationale for doing that is that cancer in a child or an adolescent is a relatively rare event overall. And so we want to make certain that we understand that it is or is not related to an underlying predisposition. That is, I would not say standard practice across pediatric oncology centers. And in fact, and Jen, I may let you talk about the study that we're doing right now, but all I will say is that there's a tremendous amount of variability from center to center in terms of what their practice is. I had a chance to speak with David Malkin when he was down visiting us, and interestingly, I had done an observership with him back in 2020, right before the pandemic. And at that time, it was not their protocol to do germline testing in all cancer patients. They only did it in, high-risk cancer patients or, patients who had recurrent cancer or a second cancer. Now that has shifted. He is actually now recommending germline testing for all of their pediatric and AYA cancer patients. And some of that is because, as Jen alluded to, when we looked at our osteosarcoma cohort, for example, we found the incidence of, TP53 mutations to be, over, as I recall, 32% is my recollection, which is very, very high when you compare it to what's reported out of Toronto or other centers. And so it appears that if you do systematic testing, you do uncover more pathogenic or likely pathogenic mutations.
Yeah, and I think this is a really important point. Is like, as I said, I feel very strongly that anyone should have germline testing, particularly anyone who has a cancer, because what we learn is cancer in an individual always affects a family. And I think it not just affects care, but it could really affect how we screen, how we approach, how we prevent patient care, and how we do preventive strategies. And I think it's probably fair to say our preventive strategies are still very much lagging behind the incredible expertise we have in approaching advanced cancer. So I think hopefully in the next 10 years, if we get our wish, we'll have more more knowledge about germline testing and more preventive strategies. And I think in part, the reason why we don't have good preventive measures is because we don't know who get cancers. But if we do preventive measure in a group of individuals who get actually a lot of cancers, we may see the benefits better. So Beth, who do we now do routine germline testing? In which cancer do we now do routine germline testing? Do you want to comment on that?
Sure. Breast cancer, it's routine. Ovarian cancer, those are the two that I know of. I'm not sure about other ones, honestly.
Metastatic prostate cancer, anyone with metastatic prostate cancer is recommended to get germline testing, and everyone with pancreatic cancer should now get germline testing. I think hopefully we'll make more of a push in anyone with colon cancer, particularly with the unusual, right side of colon cancer, small bowels, gastric cancer should get germline testing. So I think there's a rapidly increasing push to get the germline testing. However, as our dear friend and colleague Alison Kurian from Stanford published in, I think it was JAMA last year or 2 years ago, less than 10% of people who should get germline testing actually getting it. And it should be mentioned that in men it's even worse. And so I think there's still a bit of a conception that genetic mutations affect women more than they affect men, and so Jennifer, do you think more females are tested for TP53? Is that true for
pediatric? That's a really interesting question. I think without the breast cancer piece, it's not so much of a disparity in the pediatric population. But we are actually, as Arun mentioned, we're currently involved in a study across all of the UC centers. So in California, all of the pediatric cancer centers affiliated with the UC system. And we have just put out a survey actually to providers trying to really find out who is sending germline testing in which populations of patients, and if not in all, to identify some of the barriers, because I think we all have faced situations where we want to send or think we should send and haven't been able to send germline testing for various reasons. And we really want to get a handle, not just at our own institution, but really across the state. What are these barriers and how can we address them on a statewide level and hopefully ultimately a broader level? I think one barrier historically has been insurance denial, and that's an area that we are working on. I think another barrier has been just misconception in the past amongst providers, really, that if there's no strong family history of cancer, for the most part, it's not necessary. And there's more and more data coming out, some of which we've already mentioned, showing that really the incidence of germline cancer predisposition syndromes is much higher than historically was thought. I think as a pediatric oncologist, one of the most common questions I get when telling a family that their child has cancer is, why did this happen? Why did my child get leukemia or get a brain tumor? And that's really hard to not have an answer. And oftentimes we don't, but I think that's a really nice segue to say we want to do additional testing and try to find out if we can identify potentially a genetic component to this. And I would say, by and large, families want that testing done. We do explain to parents what a germline finding would mean in terms of the implications, because as you said, it really not only affects the child, but parents and siblings. And sometimes families aren't ready to get that information and don't want to do the testing, and we absolutely respect that as well. But I think by and large, families want to know, they want to do the testing. And they want to do the surveillance if indicated.
Yeah, makes sense. So, Arun, of course, more is always better, but what is satisfactory gene mutation group, right? Because again, we deal with this a lot in the breast clinic or in the adult clinic. It's like, if you have obviously, if you only have two genes, that's probably not enough. But what do you think for young people is adequate in germline testing? 20 genes, 30 genes, 500? What is it that you need? It's like, as I said, then, I mean,
Well,
of course, the
well,
more the better, right? But
no, it's a really excellent question. In patients who have a known cancer diagnosis, for example, thyroid cancer, one can certainly tailor a panel that is specific to genes that are only associated with that specific type of cancer. I would say that our approach as a whole has been to utilize the UCSF 500, so 500 gene panel. As for tumor testing, and then similarly utilizing the same platform for germline testing. However, there are certain variants. For example, I think of Dicer1 classically, which is not Li-Fraumeni syndrome, a different cancer predisposition syndrome, where there are hotspot mutations that have been identified that are not picked up by the UCSF 500 very well, particularly for like some deep intronic deletions. And so for those patients, in addition, we will often send a dedicated in vitae panel for that specific set of genes associated. I mean, specifically for Dicer1 and for the spectrum of Dicer1 variants.
And thank you for that, because I think often when I see patients for advanced cancer, or like even like I want to see the genetic panel, and I'm sure Bess wants to see the genetic panel too. And the reason for this is because we really want to know, does someone have an adequate panel for the disease they have or be screening for? And then also, do they have a variant of unknown significance? So with this, like Jennifer, are there a lot of VUSs in variant of unknown significance for TP53? And how do
We
you deal with
do.
that?
Yeah, that's a great question. We do see VUS in TP53. Probably not as often as with some other germline findings, but absolutely we see. And just so for the audience, those are variants from normal, but they're not clearly been associated with an underlying cancer predisposition syndrome. And those can be challenging. We query the database, we see what's been reported. If anyone else has had that variant, what their clinical course has been. There's some great databases available to us as clinicians. And sometimes we can't make a firm determination, and we tell families, this is what we know right now, but we would like to see you back in a year. We like to follow families in general in a comprehensive PHCC visit at least once a year, primarily to go over any new findings, any new literature that's come out. Oftentimes a VUS has been reclassified in that interim and now is considered likely pathogenic, for example. So I think it's really an evolving field. I think in general, when we have a variant found, if there's a suggestion that it might be associated with an increased risk of cancer, we disclose all of this to the family, and most families, after an informed discussion, do prefer to err on the side of caution and pursue surveillance. But I think that's a really nuanced discussion, and it depends on each family and situation.
What about in the adult clinic, Beth? Do you have patients with VUSs, and how would you address that?
We don't currently have any patients with VUSs in our clinic. I think the approach would be when a genetic counselor sees a patient, they would look at the family history. And if there is not a lot of information about the particular variant in the databases, but the family history is very suspicious for it being more likely pathogenic, those patients I would expect would be referred to the adult clinic. And then we would talk to those people about, based on their family history, here's the comprehensive screening. Based on the family history, we could make some modifications and maybe narrow it a little bit. In the same way where we have patients who have undergone testing for research purposes and found out they had TP53 mutation, but as an adult, they've never had cancer, and no one in their family has had cancer. Those patients as well, we talk about, okay, here's the set of all possible screening and all the cancer risks. We can modify that and skinny it down a little bit. What are the types of imaging? Like a whole body MRI gives you a breadth of information in a single exam, and it's very helpful. There's things like colonoscopies and upper endoscopies are very helpful, and those cancers are, particularly colon cancer, common in a lot of adults. So what are the things that we can do to adjust to their family history?
So we heard that whole body MRIs and brain MRIs are the mainstay of Li-Fraumeni testing and screening. What else do we do? Arun, in pediatrics, what else do you do?
Yeah, so we do ultrasounds to look for adrenal cortical tumors. We do a CBC
And
to
when do you start that?
So we start that fairly young, and at
Mhm.
birth, and we do every 3 month ultrasounds. Although again, we do tend to modify frequency based on the family's ability to sort of um, you know uh, 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 I guess to be able to comply with that recommendation, because
Mhm.
it can cause a great deal of financial and logistical difficulties for some families. And then we do a CBC at the same frequency, so every 3 months, looking for leukemia. As patients get older, the screening guidelines change. So as patients get into the range where they may develop, adrenal cortical carcinomas, right? We then do things like look at specific hormone levels, like, testosterone, DHEA, et cetera, that are associated with adrenal cortical tumors. And so that really is how we do this. We do it based on age. I will also say that sometimes if we have a family with a history of a tumor arising at a very early age, atypically, we will sometimes start screening sooner for that particular tumor, because obviously there's a lot we don't know yet about genotype, phenotype correlation in Li-Fraumeni syndrome, and so the family history, and I think um, Beth said this earlier, the family history is really very important in guiding our recommendations for surveillance.
Great. Jennifer, anything to ask before I ask Beth to elaborate on the adults?
Yeah, I think, well, just like Arun said, it's the ultrasound, the labs, and the MRIs. I think in the pediatric population, a real challenge that we see, in addition to families' abilities to do, every 3 month visits, as mentioned, is really the, the fear of children of having a blood draw done, right? Or inability to even, or fear of sitting still for an ultrasound. And so, in addition to just the logistical challenges, we really work with a whole team on helping families and children, I think, cope with having to come in and have these things done. We have child life specialists, we have social workers who can help the family, because that is often a large part of our challenge. And often we have families from quite far away, and we're able to work with their local primary care provider to do some ultrasound, say locally, and then some at our centers. So yeah, it's really complicated in the frequency of surveillance.
And if I can
Yeah,
just,
I think.
if I may add to that just briefly, that
Mhm.
scanxiety is a term that we use, which is a real phenomenon. So that every time a scan is performed, the patient and the family have this waiting period where they are, waiting to find out if they have a diagnosis. And so it's an incredibly traumatic experience for children and for adolescent and young adults. And so, we're really fortunate to have a multidisciplinary team and genetic counselors who are so gifted and so skilled at, interfacing with families and patients and addressing those challenges.
Yeah, and I think I can, of course, talk from personal experience, right? Having being in a screening program is like, and I think that's what I really have to say that the biggest difference for me was going from physician to patient was just to have this deep, profound understanding how much this 48 hours or whatever period is that you wait and how important it is to communicate to patients or patients asking, how long is it going to take until the results come back? Because if you know nothing comes back for 72 hours, then you have then you have 72 hours that are a bit easier. But if you think it should be back in an hour and you're waiting 72, it is a very long time. And I think so, somewhat the direct access. And I have to say, our imaging colleagues are phenomenal. I think our results come back pretty quickly and so, but yeah, the anxiety associated with scans, I think, it's pretty significant. Bess, what are we doing now for our adults 25 and older? What do you recommend for our patients with Li-Fraumeni?
What we start with is for the female patients, we start with breast MRIs once a year, starting at age 25, and breast exams in the clinic every 6 months. And we emphasize self-exams. For men and women, colonoscopies start at age 25 or sometimes even younger, depending upon family history. And colonoscopies and an upper endoscopy. Fortunately, the guideline now says that the increment of having the colonoscopy is somewhere between 2 to 5 years based on the findings from the prior colonoscopy and based on what the family history looks like. We start prostate cancer screening at 40, which is older than in the general population. And like we do with some of the other high-risk mutations, we are a little bit more prompt at referring to our urology surgical oncology team if a PSA, which is the screening test for prostate cancer, is above what it should be, especially in the younger men. A 40-year-old who has a even slightly elevated PSA, that's an unusual thing to have. And so we start that. Women, once they get to 30, we start doing mammograms. I have to tell you that there can be a lot of concern about that because one of the things we emphasize with our adult patients is that we want them to avoid radiation of any type. So when they go to an emergency room because of some sort of symptoms and need to be worked up, to tell the emergency room that the MRIs are better for them. And mammograms have some radiation. So I spend a lot of time talking to women about how little radiation there is in a mammogram and that the value of doing the screening twice a year. Pancreatic cancer, in some individuals, we include the screening if there's a family history of pancreatic cancer. And when we start would be either at 50 or depending upon the age at which it's occurred in their family. And then there's, of course, skin cancer. And I don't know if we screen skin cancer in children, but as soon as I see a patient, we start dermatology screening right away.
Yeah, we also screen with dermatology annually.
And I think the recommendation for any parent to look at their kid's skin is probably very reasonable. And like for every individual to look at the skin once in a while and ask a partner to look at their back. It's an easy accessible tumor and easy to remove at early stage. So I think it cannot be emphasized enough how challenging a screening program is in Li-Fraumeni. And then, so I'm taking a question now from one of our participants who says, like, I was diagnosed with Li-Fraumeni at 28. I'm in my 30s. Considering a mastectomy with reconstruction, like, does it make a difference if I do so before or after children? Does it impact breastfeeding? And if you want, I can answer this, having been a breast oncologist and having recommended a lot of mastectomies. The mastectomy risk reduction of cancer is probably in excess of 90%, and it will reduce the burden for breast MRIs and mammograms if we still have to do whole body MRIs. Often, if you do a risk reducing surgery, the earlier you do is, or the earliest you can emotionally wrap your head around, is the more benefit you have, right? It's like, you have more years of not doing MRIs and not doing mammograms. And I have a lot of discussion with patients about when to do a mastectomy. And I think an important part is you have to have a team in place. You want to do it when it's convenient. You don't want to do your mastectomy when you also have finals. Or if you have like a very stressful time in your life. I think it's like, it does take time out of your life. So I think it's not as much as what's the right age. It's when are you ready for it, and when have you had the time to prepare for. I think the one thing that I see is really challenging is, like, you have a mammogram that's abnormal, and then you have a biopsy that's abnormal, and then everything has to be done in the next few weeks. And I think it's, for someone who likely gonna have a mastectomy after diagnosis of breast cancer, that is incredibly stressful in addition to everything else. So I think once we start talking about risk reducing surgeries, start thinking how and when and with whom and who's going to be there for you. So I think just the planning becomes really important. It does impact breastfeeding. If you have no breasts, you can't breastfeed. So I think waiting for childbearing times to end is probably a good thing. That means like more uncertainty before. But so anyone who would like to add anything to this? Beth?
Well, the patients I talked to about Li-Fraumeni about their breast surgery are very similar to the patients who have BRCA1, because what they have in common is they have pretty early onset of breast cancer. And so one of the things that we talk about is, based on how old they are at that moment, how many children do they want to have? So I had a patient the other day who said that she wanted 4 kids, which I was really good for her. And she's already 30. And I said, so reasonably speaking, you're going to be probably 40 when you finish having children. And then you want your kids to be old enough that they can get into a car seat and you don't have to put them into a crib before you do mastectomies. And so you're maybe talking about 42, 43. And the average age of onset of breast cancers in the 30s for women who have Li-Fraumeni and BRCA1. And so, yes, you can do that, but your odds of getting cancer are already pretty increased during that time when you're having your children. How much additional anxiety is that going to add, particularly since you can't do breast cancer screening effectively during certain parts of pregnancy? And we can do some kinds of imaging, but the quality, like with breastfeeding, is not always great. So it is a very personal decision, but we have that whole conversation about what and when.
Yeah, that being said, though, we don't want to cause more anxiety. But if someone presents with breast cancer, that means, if it's triple negative, that means 6 months of chemo and a year of immunotherapy. If it's ER positive, that often means 5 to 10 years of hormonal therapy with ovarian suppression. So, for someone at high risk for breast cancer, I just think do anything you can to not get there, because while most breast cancer is survivable, our survivals of breast cancer are really, really good and really high. getting there is not, because breast cancer therapy is not a walk in the park. So then, of course, there was a question, is like, as you mentioned, ovarian cancer risk reduction for ovarian cancer. And there was a question, one of the participants is like, should someone with Li-Fraumeni have a risk-reducing oophorectomy and hysterectomy? How are we dealing with this? Yeah, are you expecting the guidelines to change?
I don't really know. I think we have to rely upon the fact that there's a amazing process where cancers that are associated with hereditary syndromes, that information gets reported up to databases where this information is collected, and there's people watching and doing analysis on how frequently certain cancers are showing up. And if something starts showing up at a higher percentage relative to the general population, then you have to start thinking about, is it necessary to or appropriate to consider risk reduction, and at what age? To me, the challenge in Li-Fraumeni is there can be so many different types of cancers, and even the list of cancers that we have for Li-Fraumeni, it doesn't encompass all the cancers that people can get. Like ovarian cancer is not a cancer that's listed as Li-Fraumeni. And so we can't have people removing all of the organs that anybody gets cancer in. Yet, I just trust in the fact that we have a really good system in place to analyze this data and make recommendations, and we keep up to date as best we can on those recommendations.
And I think it's fair to say, like, a lot of the guidelines are rapidly changing. And I think, which is another reason why we think having a hereditary cancer clinic or a pediatric hereditary cancer clinic is that our patients actually benefit from the research updates that we have, and get access to the latest recommendations and interventions. So I think that's part of why I feel really proud of what we do. It's like so let's go back a little bit on the nitty-gritty. It's like what's this deal with radiation exposure? Jennifer, Arun, is like are we totally avoiding radiation? Like are people not allowed to go through the airport X-ray thingy, or like how do we handle this in real life?
Yeah, I think that's a really good and a practical question. I think when it comes to imaging, of course, we as providers always try to recommend the type of imaging modality that does not carry radiation or carries the least amount. So, for example, an MRI over a CT scan, or avoidance of a lot of X-rays. Therapeutically, we really use this information to help us guide our treatment for patients. So, for example, for certain types of sarcomas, we sometimes will have a surgical resection of the primary tumor, and sometimes we'll pursue radiation of the primary tumor. And if we know that a patient has a underlying cancer predisposition syndrome, such as Li-Fraumeni, we will push much harder to have our surgeons resect that primary tumor versus doing radiation either in addition or in lieu of the surgical resection. And sometimes that means, being willing to accept a little bit more risk from a surgical standpoint, because we know of the risk associated with malignancies with radiation. Sometimes when we have patients with leukemia, we're thinking about irradiation as a part of their treatment plan, and we would often move away from that for patients with Li-Fraumeni. I think day-to-day radiation exposures like air travel are so low that I would not advise patients to avoid flying on an airplane, right? I think that the amount of radiation we get from like a CT scan is so much greater than some of that background radiation that I think we have to find that balance. And some families don't, feel more comfortable avoiding things like air travel altogether, but we would definitely not recommend that for everyone with Li-Fraumeni lifelong, because, again, it's a matter of finding the practical balance that works for each patient.
Yeah, and I would say that we try to use low dose CT when we use.
Mhm.
So, and there is some emerging data that low dose CT is significantly safer than a conventional CT scan. And then there are times, for example, with adrenal cortical carcinoma, when it's metastatic to brain, where surgery is not necessarily feasible. And then we are forced to rely on radiotherapy in those instances. So there are obviously exceptions where we use it where it's necessary for treatment of a patient's acute, cancer.
So that's bringing up to a question that just popped up is like, could a child with Li-Fraumeni be spared this intensive screening if there's no family history of pediatric cancer? Or can they do less intensive screening? And I would say that's everyone is different, but I'm sure, Arun, you have a more specific answer.
Yeah, it's interesting. So, I had this conversation with David when he was down. Given that we know that there are certain genetic mutations that seem to carry a lower risk. That being said, we are not at the place right now where we can do reduced intensity screening based on either family history or based on the genotype. Our current recommendation, though, is to work with families and to do the level of screening that works for them as a family. But, you know, I would not propose or recommend reducing the frequency of screening in a child who has a pathogenic or likely pathogenic Li-Fraumeni germline variant from the get-go. I think that really is a discussion of risks and benefits with the family and partnering with them in that decision making.
Thank you, Jennifer. Anything to add? How do you approach this when someone said, can I do less?
Jen, are you frozen? I think you might be frozen.
You're mute also.
I don't know if she heard the question.
Sorry, was that a question for me? Everybody kind of
Yeah, so
froze on me for a minute there. I'm so
uh,
sorry.
so how do you approach when the family asks you like we don't see any childhood cancers, can we do less for our child?
Yeah, I think like Arun said, there are certain specific alterations in the TP53 gene that seem to be associated with decreased risk of cancers, and certainly the family history is important. That said, there is no consensus guidelines on minimizing or decreasing the surveillance for certain populations. But again, I think, we're constantly learning more about this condition. And even in the last, 5 years, the amount of knowledge that we have is much more than we had 5 years ago. And so what I like to, have that discussion with my families is that as of right now in time, the consensus guidelines are to do this surveillance for all patients, but it is possible, and in some cases even likely, that this may change over the next several years. And so let's keep that discussion going, and let's continue to check in. And there may be a time where we can say this specific alteration, or, if in an absence of family history, yes, we have proof that it is okay to omit these scans, etc.
Yeah, and I think what I'm really hopeful for is like, I think the big challenge is we don't have a blueprint who gets what cancer by when and if. And I think with these uncertainties, and we certainly all have seen, like I've seen many BRCA carriers where no one has, if no family member has cancer and the person presents with breast cancer at 29, right? And you go like, how did this happen? So I think um, we I think what both Arun and Jennifer are saying, we're just not sure that you're safe from cancer just because you don't see it in a family member. And for us, because we are worried about someone having a cancer, we'll try to do anything to prevent this from happening or detect it early. And I think it's not that we want to do all this screening. We just really worried about cancer that we could prevent. And I think that's giving a little bit perspective. And a screening program is really hard. And I think a parent who helps their child to get through a screening program and often has to go through their own screening program. We have the greatest respect for you for doing this. It's like I think what I always learned as being a physician is how amazing a lot of people are. It's like I said, how privileged we are to be able to care for amazing individuals. So, but going back to another mundane question, are there any medications or anything that you think should be avoided? Any lifestyle choices that you think should be avoided? Let's start with Beth. Beth, what do you tell people?
Please don't smoke. Please, please, please don't smoke. Alcohol in moderation, and if you can do without it, do without it. Try to stay away from preserved meats, roasted meats, things like salami and things like that. Try to eat a healthy diet and maintain a healthy weight, and exercise, 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 keep a healthy body. Try not to eat so much processed food if you can. The amount of highly processed food in the American diet is just really kind of makes you wonder about the increases in colon cancer. So those are the main things that I talk about in terms of food.
I think
Okay, how about
minimizing the risk of sun exposure too. I would just add to, so wearing sunscreen and trying to avoid, being in direct sunlight in the peak sun hours in the middle of the day. Even for our families who are, don't tend to burn, there is that risk of increased risk of skin cancer. So wearing hats and sunscreen, etc. And oftentimes for children, that includes talking to teachers and schools and coaches, because a lot of times the children are out of the house during that part of the day. So I think that's another important piece of it.
Arun?
Yeah, no, I would agree with everything that was said. I mean, smoking, avoiding direct solar exposure. Our patients are, the younger patients are certainly in a more controlled environment by their parents, but as they become teenagers and young adults, we do a lot of anticipatory guidance around things like healthy lifestyle choices, exercise, avoidance of additional risk through smoking, diet, as Beth touched upon. I think all of the things that she mentioned are things that we would talk to our families about, our patients.
So for individual with BRCA mutations or a similar HRD mutation, I think the benefits of exercise are more and more established. Is there much data for exercise for Li-Fraumeni?
I'm not aware of a lot of data specific to Li-Fraumeni. It is certainly generally in terms of cancer risk a known risk factor. So it stands to reason that trying to keep your weight down would be, one of the ways that you can mitigate risk. But I'm not aware of specific data on Li-Fraumeni regarding exercise. I don't know, Jen, if you are.
No, not specifically for cancer prevention. I mean, we do have really good data um, on cure rates being related to, baseline obesity, et cetera. Leukemia is sort of the type of cancer in which that was discovered earlier than others. And we know that children and young adults who are overweight, who develop leukemia, often have more resistance to chemotherapy and often have a higher risk of relapse. And so even from that standpoint, I think maintaining a healthy weight is definitely important. Yeah, and then I would just add to that too, making sure to see a physician annually at least, and really, I think in the teenage population, there's this tendency to minimize new physical findings, and teenagers are invincible, and nothing ever really seems wrong with their health. And we unfortunately see patients who have had a lump or a mass that's been there for 6, 8, 9, 12 months, and they, for whatever reason, they thought it was nothing. They didn't want to be different. All of the reasons is really just emphasize the need to seek medical care as soon as you notice anything. And if it's benign or nothing to worry about, that's fantastic, but really to be proactive in that.
So let's talk a little bit about family planning and parenting, how to talk to a child about the mutations. Like one of our participants asking is like, is IVF the only way to guarantee not passing on the gene? Arun, shall we start with you?
Sure. I'm sorry, could you repeat the question?
Is IVF, in vitro fertilization, the only way to guarantee not passing on the gene?
I mean, in terms of pre-implantation selection, I mean, I think it's a very expensive endeavor to do, and most of our families actually don't have the resources to resort to that. And I really think that the effectiveness of our screening protocols, and I think that's another really important point I'd like to make, is that we have now solid data on Li-Fraumeni as well as other cancer predisposition syndromes that screening increases overall survival and event-free survival. And so I would say that practically, I don't feel like IVF is something that we recommend to our families or patients. I feel like it's a high bar for many of them, but rather identifying and then entering a screening program, at birth, I think is a far more, effective strategy.
Yeah, I think, this is a very complex and extremely personal question. So what we're talking about is like, could you harvest your oocyte or eggs and then fertilize them and then test those fertilized embryos for the mutation, then only select the ones that don't have a mutation? We can do this technically. It's fairly routinely done. It is very, as I said, very personal. And to quote my son, who says, I'm grateful that my mom didn't do it because otherwise I wouldn't be here. So, as much as, and I think we can do a lot of things technically, a lot of things are feasible. Whether we should or shouldn't do this, we don't want to judge, and we want to have people have an opportunity to make choices. But it's a very personal choice, and we don't make, I think it just be very clear, we offer opportunities, we don't make recommendations. And this is not a straightforward discussion with anyone. But yes, if you have a baby without planning, there's a 50-50 chance that the baby has a mutation. But 50% will not. And I think as you heard in this panel, like we have made incredible strides with screening and early interventions. So while there's an opportunity to remove the mutation from the gene pool, there'll be an opportunity not to have to. And I think being in our program hopefully will help you sort out some of these discussions. That being said, though, then if you have a child and the child has the mutation, when does the parent start talking about this? I mean, at some point, the child is going to be curious why they have to go to the doctor every 3 months when their friends don't. Jennifer, how do you approach this? How do parents,
Yeah,
what do you
that's a
recommend?
really, yeah, it's a common discussion point that we get. I think that it's a little bit different whether there's a parent who also, or an older family member of any sort that also carries that specific mutation. I think in many ways it can be easier for families in that situation because it's sort of normalized, in terms of, well, I have to get an MRI every year, and you just have to do the same because it's part of keeping us healthy. It really is, we view it as a part of preventative care, just like getting childhood vaccines and, getting a vision screen and a hearing screen. Um, so I think when there's a parent already going through a similar surveillance, it's sometimes easier in that sense. Um, but it is a really common concern, how to tell children that they're different and they carry a higher risk for cancer. I think that young children, sort of what they're told and what they do is just normal to them. And so, in many ways, the younger children, it's a little bit easier. And I think it's sort of the adolescent age when it's can be the hardest emotionally. I think that our genetic counselors are really amazing at helping walk parents through sort of before even having the discussion with the child. How are we going to let them know about this, really focusing on the benefits of doing the screening right. If we can catch it, it's very treatable, and we want to make sure that that you live a long life, and this is why we need to do this. We have our genetic counselors meet with parents first sometimes, and then meet with family children. We are also available to meet with parents first and then discuss with children. And it's really a personal discussion, an individual discussion. But that's often a large part of our PHCC visits, is really talking with parents on sort of how to help their children cope with this and normalize it as much as possible. Yeah.
And do you see strategies that work better than others?
Um,
Arun, you want to start there?
sure, yeah. I mean, I think meeting the child at the age that they're at and the developmental level that they're at is crucial. So, for example, there are a number of cartoon books that are available. One of them is Emily Goes to the Doctor. And they are, ways to introduce children to the concept of screening for Li-Fraumeni syndrome that are easy to understand, colorful and very user friendly. So I think that our genetic counselors certainly tap into resources like that to talk to patients and families. My experience is that on the very first encounter, the even the older children don't usually have a lot of questions for us. They kind of just passively take in the information and let it sit with them. And so the key is to come back to that question later in their journey and give them the opportunity to express what their concerns are, because it's not that they don't understand, or it's not that they don't have concerns or aren't feeling the impact, but I think that the information can be so overwhelming that first time that you speak with them, that it's good to let them digest it and then come back to it when they've had a chance to assimilate that information.
Yes, anything
Oh,
you would? Oh, sorry, Jennifer,
Oh, sorry.
Beth.
I was also just going to add too, I think probably many of our attendees today are familiar with the resources, but there are great groups online available, through Li-Fraumeni Syndrome Association, through Facebook groups that help provide, I think, support, for parents, but also for children and teens with this diagnosis. So, many times families and children feel more comfortable talking about this type of thing with others who have the same condition, maybe rather than their peers who don't. And so we like to connect families to support groups like that.
That's great. Beth and the adult, I'm sure you get asked what women should tell their children and what men should tell their children.
We do. And we talk about, testing if somebody has children. Usually, if somebody has children, that conversation happens even with the genetic counselors to begin with. And if it's a new diagnosis of Li-Fraumeni, some of those patients will then be referred to the children's clinic if they have young children. If they have adult children, many of those children end up in our clinic, the young adults in our clinic as well. Our genetic counselors are amazing at helping parents when they talk to their kids, when it's time for their children to get tested. More so with the other syndromes where cancers are more commonly occur as an adult. I'm confident with the Li-Fraumeni patients. We have a couple of genetic counselors that really focus on that. They work hand in hand with the children's clinic to make sure that there's a clean transition for all of the family members to whatever clinic is the one that's appropriate for their age. So the parents know that not only are they being taken care of in our clinic, but they have their children taken care of in the children's clinic.
Really helpful. So let's switch over to the future. What's on the horizon? I think one of the great hopes are that we have blood-based testing, that we find circulating DNA, pieces of DNA, pieces of tumors, pieces of protein, pieces of like floating around the bloodstream that tells us early. Arun, you want to talk a little bit about what we call liquid biopsy, so multi-cancer early detection? There's different names for the same thing.
Certainly, yeah. So it is actually currently being tested in a clinical trial at sick kids, and we're actually hoping that we will join that trial when they start recruiting other centers. Um, Dr. Malkin shared some very interesting, albeit preliminary data that showed that you could use circulating tumor DNA, what we also call liquid biopsy, to detect the development of cancer early. In fact, much earlier than when scans detect the cancer. So I think we all hope that that becomes validated in a larger cohort of patients, because certainly, we know that if we can detect cancer early, the outcomes are far more favorable. That's why screening protocols work. And being able to move that time point even sooner does offer, I think, great hope for improving upon the advances that we've made in screening for Li-Fraumeni.
Yeah, I
Jennifer?
agree completely. And then, I think looking even beyond that would be the hope that maybe one day the blood test can take the place of imaging, right? If we can validate that we have a sensitive enough assay to pick up circulating tumor DNA, then ideally in a future state, we can just do blood draws and avoid the time and the anxiety and the sedation sometimes associated with MRIs or even ultrasounds. Yeah, and we do have some precedent in cancer in general where we've been able to replace imaging studies with blood tests, for example, or urine tests. And so I think it's a reality. I think within our lifetime we will get there. And for many of our patients, that will be a reality. We just, I think, need to be really clear with families that this isn't proven yet to take the place of our standard surveillance.
Yeah, and I would say like at least for our side, we are like about to embark in a couple of pilot trials with the particularly to doing the liquid biopsies in our high-risk patients population, which I think is where we may have a much quicker answer. I think the reason why this is so slow is because it takes a long time to find enough people who develop cancer in the time we do these tests. Whereas if we're dealing with the high-risk patients population who actually get cancers, that'd be much quicker. So I think we are all very excited about this. And I think at least, as I said again, speaking for someone who actually gets into a screening, is in a screening program, if you only had to do half the imaging, we would still be extremely happy, right? It's like, I mean, even if the imaging doesn't go away completely, just doing half of it would be great. Um, and then that's exactly what I'm hearing in another question is like, I live somewhat remote and have a lot of trouble getting referred to a genetic counselor. The primary doctor recommended a Gallery test, which will not be covered by insurance. I'm curious about the recommendation here. The only screening for me is breast cancer since the community is not familiar with Li-Fraumeni locally. So I think that first thing would be like, please come see us. Please make an appointment with us. And I think probably if you can see you twice a year and get all the things done in that time, that'd be great. I would just caution against the Gallery test. The Gallery test is not really completely geared to doing early detections. Detects a lot of cancers that advance. It's not been great for breast cancer. The Gallery test is not being great for early breast cancer, not being great for early prostate cancer. So I think not as good for other cancers that we could actually prevent. So please don't do the Gallery test. If you have Li-Fraumeni, come see us. Jennifer, you want to add anything? I assume participant is an adult.
Oh, yeah. I mean, I definitely would defer to you, Dr. Munster, on the adult recommendation. But I will say that this is, we have a lot of families with this same challenge. And I think, from our standpoint, even if you do 50% of the screening, that's better than none. And so we really, we have Li-Fraumeni patients who have whole body MRI every 3 years or every 2 years instead of every year. And we work with families. We try our best to try to be creative and figure out if there's a local imaging center, for example, where we can send orders, or various ways to get it done. But it's a huge burden. I think the frequency of surveillance in Li-Fraumeni is we recognize this as providers, even just taking the day off of work or of school and the travel involved. So, we have our standard, here's our recommendation, and then we really talk it over with families and try to come to a compromise. Some people end up getting every 6-month ultrasounds versus every 3 to 4 month. And, that's the best we're able to do. So I think, the video visit has also been really key. Ideally, we want to see every single patient in person just to do that hands-on physical exam, right? And look for the physical exam findings that we worry about. But if that's not possible, we at least can do a video visit. And it's pretty amazing the amount of exam we can do over video. And also we can call the local provider and walk them through kind of what to look out for and be creative in our approach to try to make sure that people get the screening they should. Yeah.
And I think the person who's asking the question, I think you should seek out our clinic. I think Beth will help you figure out your care. And if your insurance covers other states, not California, what we do is that we have the imaging done in your home state and just have you come for the visit, and we work with your local provider. It is a pretty specific syndrome. It's Dr. Michlitsch, Rangaswami, and us, we spend our life focused on on hereditary cancer mutation. Pediatricians and primary care docs in the community have to deal with a very large group of diseases and illnesses and stuff like this. It's not surprising that they're not familiar with this. This is very specialized expertise that we're proud of, that I think we can offer a lot, and I think we'll make it work for most people. I think BEST goes above and beyond finding people the right screening, right approach for adults. And then I think you have two genetically untested teenagers who probably should get tested sooner rather than later. Because it's one thing to have a cancer, it's a whole different ballgame having a child with a cancer that you could have prevented, because that is really, really difficult to deal with. So I would just urge you, please bring your kids in, bring yourself in.
Yeah, and
We
I'll
are,
just one thing to add to that, sorry, is that we really have the ability to mail kits to families as well. So if that's a barrier, coming in for the testing, we are almost always able to arrange for a buccal swab kit to go to families' homes, where it's like a little Q-tip you rub on the inside of your cheek and send it in that way. So we don't want that to be a barrier for our families. Yeah.
and then the other thing too, I think every parent immediately thinks like your child is going to be positive, but you may actually learn that your child is not positive and that you worried already 15 years about something that actually is not there. And I have to say, I cried the whole night when I found out that my daughter's negative. So there's some of these things that are just really good to know about when you carry a gene mutation, because 50% of the kids don't have it. And so we have 2 minutes. Arun, any closing comments?
No, I think this has been a wonderful opportunity to talk about this. I think that, as Jen said, I look forward to a future where we're going to be able to do much better than what we're doing now. And potentially, even some therapies that may be tailored towards patients with Li-Fraumeni syndrome, which are, there is, for example, metformin that's in clinical trials right now at the NCI and SickKids. So, we don't have the results of that trial, but there are other agents that I think are in the pipeline, and we hope that those can be used to prevent the development of cancers as well. So I look forward to the future when that will be the case.
Jennifer?
Yeah, I just wanted to thank everyone for inviting us, and I'm happy to be anyone can feel free to email me with any additional questions later today or in the future. My email address is just my first name dot last name at ucsf.edu. And if thoughts come up, questions come up, questions that you didn't want to ask in the larger group forum, always happy to help try to answer. And if I can't help, find the person who can within our large organization. So,
And likewise.
yeah, thank you all. Yeah.
Yes.
Well, I just want to thank you, Pamela, for allowing us to dedicate one of these workshops to this wonderful population of patients. I'm always surprised at how resilient and courageous people are when they're faced with syndromes like this, and especially the ones that are having to deal with cancers. They come through it and they keep fighting and keep doing what needs to be done, and we will be there to help them in any way we can.
Thank you all for this amazing 90 minutes. I learned a lot, and I also like to thank Letitia Taniwaki, who is making this workshop logistically work, getting the speakers together, and Danielle Sipes for the flyer. There's a lot of work in the background. And again, all three of you, thanks for your amazing comments and for doing this. Much appreciated, and good evening.
Thank you, Pam. Thanks, everybody.
Thank you.
Bye-bye.